Welcome, everybody. I'm delighted to kick things off. I hope we're not trying to squeeze in too much information in a short period of time, because I think all of these talks have gotten more intense with much more information. And certainly when it comes to therapeutics for Crohn's and ulcerative colitis, the field has really exploded recently. So it's very exciting, but it also makes it somewhat confusing. So I will try to keep it clear and clean for you, and try to give you some very, let's say, slimmed down takeaways for this so that you can use them practically. Here are just my disclosures. So what are our options? Well, it's really expanded. When many of us started in the field, when I started in the field, we had very little other than some of these things on the right, particularly azathioprine and mesalamine. But now it's exploded in a way that's very exciting and makes it somewhat confusing. So how do we sort through this huge list? How do we do it so that we really take advantage of all that's here? I think there's a tendency of us to say, all right, well, I'm familiar and comfortable with these three or four. Let me use this. But we want to really expand our repertoire so that we can offer our patients the most broad array of possible medications that we can. So the old paradigm was really this, that sort of you slowly increase as severity goes. And we're revising that in some significant ways so that it's not just sort of saving the, let's not say necessarily the best for last, but the latest for last. But we want to really rethink this. And it's not just a matter of reserving these more powerful or newer therapeutics for the very end, but really changing our approach. So really inverting this whole paradigm to using some of these agents that are more effective earlier in the disease course. Now, we have this idea of a hope and promise of personalized medicine, but really so far we don't have any clear genetic, cytokine, or clinical profile that clearly defines a subset. I think some of the newer agents coming down the line will have clear biomarkers, but we're not there yet. And so we need to go particularly by these other characteristics. And what data can guide a particular medication in a particular subset of patients? Well, when we go by some of, say, the ulcerative colitis guidelines, and I think at least these broad issues are applicable, as we can really think in terms of disease severity, in terms of prior and current therapies that the patient's been on, safety, and cost. So when we look at those criteria, we'll talk a little bit about risk and safety based on age and some of the data that's been there. What complications has the patient had? Are there extraintestinal manifestations? Are there joint pains? Are there pyoderma gangrenosum or other things which would lead us away from a GI-specific therapy such as vedolizumab or Entyvio and towards something that's going to be more systemic in terms of treating the extraintestinal manifestations? What's the patient's history been in terms of infectious risk, cancer history, pregnancy, and obviously patient preference? And with that, some of these are oral, some of these are infusions, some of these injections, and that comes into it, as well as, to an extent, cost, because ultimately, is it insurance companies that end up guiding what we can do, at least in the United States? And then, obviously, a central issue is efficacy. Can we get to remission? Can we really get to a deeper healing, a prevention of hospitalization, reduction of healthcare utilization, and then timing? Now, a lot of these come into play when you're talking about a second or third line therapy. And in this talk, I'm really focusing in on just what's the first line therapy. And in particular, then also durability. There's real problems with churning, that you start someone on one therapy and then they develop antibodies to it and then they go on to the next one. And so one of the factors that's important in choosing is also persistence of benefit. There's flares and loss of response that goes with that. And so we want to minimize that. So everyone out there who's presenting their medication wants to be first, but really which, who, and when are the issues. And the key principle is really the aim is deep remission. So we're not just trying to get someone better. When you look at these therapies, a lot of the results will be remission and response. Well, response is good, but we really want to try to get to the extent possible a deep remission. The first biologic is really critical. So when we look at, say, the response to vedolizumab, we see clearly that those who've been on an anti-TNF prior to going on vedolizumab don't respond quite as well when vedolizumab is the second-line agent. So that's important. How does that influence it is important to think about, because you only have one shot at that first, and you want to make sure it's optimized right away so that you don't need necessarily to go on to a second one for at least a long time. And then also you want to treat early. There's increasing data that we'll go over briefly that if you wait too long and someone's gotten more complicated disease, then somebody might not respond as effectively, or they might develop more complications. And you need to profile the patient as best you can in a variety of ways. And when you look here in terms of what's the risk of or what's the benefit to long-term outcomes in achieving really a stringent endoscopic and histologic remission, so that patients who have more rigorous treatment endpoints, and we're talking about not just do you feel better, yes, but endoscopic and histologic remission, had a substantially lower risk of clinical relapse compared to patients who achieved remission but without that deeper remission. So when you have an endoscopic score of 1 versus 0, a significant reduction of 50% of risk during that next year. And then if you can even get histologic remission, you're reducing that even further over that. So when we talk about trying to treat aggressively, there's a real significant benefit that we need to keep in mind when we're treating our patients. So what are our first-line choices? Well, for ulcerative colitis, we have a set here, and the newer ones, the tofacitinib, upadacitinib, ozanimod, and etrasimod are really important to keep in mind. And then mirikizumab is the latest. We still have some of the older tricks. We really are trying to avoid steroids as much as possible. Some of these newer agents really can kick in very quickly. And so even though there can be some time lost in terms of prior authorization, and if you need to set up an infusion, that can take some time. We'd like to avoid steroids as much as possible. And then when we look at these in Crohn's, the list is substantial. Now, we have to keep in mind that when we talk about these biologics, clinical practice really should be changing more than it has. And this is a study done by Corey Siegel a little while ago. And so maybe the more recent data is slightly better, but I don't think it's very much better. And what this is looking at is someone has a flare, what are they being put on? This is for Crohn's, and this is steroids first, along with 5-ASA, which don't really work very well in Crohn's. And then you see here, there's a relatively small number getting biologics. So then a little bit, this is the second flare, and this is the third flare. And so when we look in some, along here, the number of people who are getting more appropriate therapy and is limited. So up to 63% of patients initiated on steroids were only managed by steroids. Some were on steroids for up to 10 cycles. So that's really not optimal management. When you start a steroid, you need to be thinking about what's your next step. These are Band-Aids. They're not effective for long-term therapy. And so that's where these other things come in. So steroids are really not first-line therapy. They can be a bridge to something, but really just a bridge and not long-term therapy, both because they have so much side effects they wouldn't be approved by the FDA, and also because they're not effective for long-term therapy. And when we look, hopefully this has changed a little bit, but it's not that long ago. This is 7 years ago. The percentage of people with Crohn's or UC who have been treated with biologics in the United States were relatively small. So it's important to change that. Now, does that mean that everyone needs a biologic? Not at all. Certainly, there is a substantial percentage of people with ulcerative colitis who just respond to mesalamine or sulfasalazine as a first-line mild to moderate disease. And so we want to follow up if you start on that with a calprotectin or a scope and make sure that they're doing well. And they might need something more, but at least Not everybody needs that. In Crohn's, mesalamine's not effective, and it's not effective for post-op prevention of recurrence. When to start someone post-op, that's a separate set of questions that people will be discussing elsewhere. There may be a subset of people with colonic Crohn's that respond, but for the most part, that's limited also in terms of duration of benefit. So how do we come down? How do we really decide this? Well, there are some direct head-to-head trials that's limited, unlike other fields like psoriasis, where there are numerous. We have, though, a growing number. We have 4 that we'll be talking about. There's comparative efficacy trials. It's a little bit tough to compare across trials, but we'll do a little bit of that. And then that's sort of, at least that tries to weigh so that similar kind of entry criteria, but just comparing raw randomized clinical trials is tough. We do that. There's other ways of doing it with sort of network meta-analyses that we were talking about. But still, with almost all these drugs, we're really talking about a therapeutic ceiling of about 20 to 25% over placebo. So that's why we have so many, because there's still a substantial proportion of people who don't respond. And then often there's some churning that goes on in terms of switching. So when we look in terms of the direct comparative efficacy trials, we have these 4. One in ulcerative colitis, adalimumab versus vedolizumab, and then 3 in Crohn's. And when we look at sort of the short story results here, and we'll go over this in more detail, it's interesting that the vedolizumab was superior to adalimumab as a new agent. The results of Seaview, ustekinumab was very similar to adalimumab, perhaps a little bit of a safety signal, better for ustekinumab. And ustekinumab then versus risankizumab, we'll talk about this a little bit, and that was really risankizumab or Skyrizi was much better. And then Sonic, which is an old study, azathioprine versus infliximab versus both were better. So we're going to use this as an important guide because this is really important information of head-to-head studies that are more directly applicable. One important caveat for all of these is that when you look at the patient that is right in front of you, most often we're using data from a clinical trial they might not have been a candidate for. They might not have qualified. Having said that, we just need to sort of interpret the data, keeping that in mind. So what's better for first-line moderate to severe ulcerative colitis, an anti-TNF versus vedolizumab. So in this particular one, they were studying adalimumab versus vedolizumab. Now here in the red is vedolizumab, and in the blue is adalimumab. And you can see across the way here that there is a numerical and statistical improvement, particularly when you're looking at, and this is remission on top, and this is endoscopic improvement, but when you're particularly looking at the difference in terms of no previous anti-TNF therapy versus those who have been on previous. So we're talking about for first line, you can see here, this is a significant difference between the two, and keeping that in mind. And there's also a question of whether there's a safety signal. Now, is it that is in favor of vedolizumab, but that's softer. So the question is it a fair comparison? Everybody draws on Humira because compared to infliximab, compared to other things in ulcerative colitis, adalimumab, Humira, or now the biosimilars do much less well compared to everything else. So is it fair? Or are they just taking sort of the lowest hanging fruit and trying to beat on that? Well, when they went up to a higher dose of adalimumab and compared that to the standard dose, you can see here that there really wasn't a big difference. And why there is this marked difference here, this is the high dose versus the standard dose, it really wasn't different. So it wasn't just a matter of, well, if you had gone up to a higher dose of adalimumab, you'd have a better response. We don't know exactly why this is because it differs quite a bit from the infliximab data. Is this clearly better than others? So if you look at infliximab and ulcerative colitis, the response rates are much higher. Now, this isn't a head-to-head trial. Then if you look at golimumab, if you look at vedolizumab here, you know, is vedolizumab better than infliximab? Well, certainly from the data we have, it's hard to say. Perhaps if we're going by the Gemini studies in terms of results of vedolizumab, but here you have the adalimumab studies in the middle, and so I would say that certainly compared to adalimumab, vedolizumab seems superior. Compared to infliximab, that's not clear from the data we have. And so when we compare the two, fast onset, better efficacy in Crohn's, antibody risk in both. Is it as safe? Not clear. There's probably more of a lymphoma risk. And there's a suggestion that vedolizumab is safer. It's slow onset, but not very slow. So you'll see response in as little as 4 weeks. Better efficacy, possibly at least compared to adalimumab, but not infliximab. And there is an antibody risk, probably less than infliximab, maybe closer to what it is for adalimumab, maybe safer because it's so GI specific. It doesn't really suppress immune function. Vaccines are normal response in someone who has vedolizumab, and so maybe better. And not any clear lymphoma risk that's been well identified. And again, didn't come up. We wanted to make sure that you realize that the data is superior for infliximab, and that really it's compared to adalimumab. So if you're arguing with the insurance company and the insurance company says, oh, we want to really go with the adalimumab first, really you should push back and say the data is far inferior. And if you're insisting on an anti-TNF, we should go with infliximab. It may be that that calculus is changing in terms of which the insurance companies will want, since we can now go from the infusions and transfer over to an injectable form. And when we look here, the odds ratio higher as we go further to the right. This is for ulcerative colitis, and we compare along the left the different agents for response, remission, and mucosal healing. More or less they overlap, but you can see there's a significant difference that almost doesn't between adalimumab and infliximab, reinforcing that. Golimumab is in the middle, or Simponi, and I'm sorry, they want us to stay away from using trade names, but it gets confusing when you're using so many of these different ones. So just to be clear, we're talking about vedolizumab being Entyvio currently, adalimumab being Humira, or all the different biosimilars, golimumab being Simponi, and infliximab being now Inflectra, as well as some of the other ones that are out there, as well as Remicade. And not to forget some of the newer ones, and some of them, ozanimod, there's a subgroup who responds very quickly to this, as early as day 5. And that's a subgroup, it's not across the board. But then those people who respond very quickly and have perhaps some particular profile that hasn't been well identified have a real durable response. So really trying to layer this in as another choice that you have that can be both quick and effective and have a good, long, durable response. Now, we've talked about vedolizumab versus an anti-TNF. How about tofacitinib versus vedolizumab? And when we look at this in bio-naive ulcerative colitis patients, this isn't a head-to-head trial, but they were doing a sort of virtual trial here, and this was adjusted for drug persistence. You can see the top line here is vedolizumab versus tofacitinib, and so giving a favor to vedolizumab and appearing that that might be better as a first-line agent here as well. Etrasimod is also an attractive agent. I just want to, there's less been done in terms of either head-to-head or comparative efficacy trials, but I wanted to make sure I put this in there because it can have a fairly substantial response over time. And you can see here, this is at week 12 and week 52, a very low placebo response for remission compared to the active drug of etrasimod at 2 milligrams, and getting a difference of close to 20% there. And here a good sort of sustained benefit over time. So when we're looking at JAK inhibitors, tofacitinib or upadacitinib, uh, they both can be quick acting. There is a role perhaps even for inpatient treatment, perhaps at a slightly higher dose if someone's being started then, and then you can start longer term as an outpatient. There's tends to be a very good durable response without any immunogenicity issues because these are small molecules and not biologics. There is some safety concern. There's thrombosis in elderly RA patients, though in the ulcerative colitis database, it seems very good. It is a more potent immune suppressant than something like vedolizumab, and so certainly being concerned about infectious risk. But in the data we have on ulcerative colitis, it looked remarkably safe. It's an oral agent. You do need to monitor closely, both in terms of cholesterol and in terms of lymphocytes, and there is a concern over cardiovascular risk, and perhaps we need to monitor people longer than in the initial clinical trials. But there's a concern, and then there's some data that we'll look at whether upadacitinib or Rinvoq is safer than tofacitinib or Xeljanz. And safety might be dose dependent, at least from the data we have in tofa. So in this study here, where they were looking in comparative efficacy in terms of real world data, this out of MGH, and looking at TOFA versus UPA, there's here is improvement and the darker is remission. And you can see here that there looks like there is a significant benefit that's greater for the UPA or the Rinvoq. And then those who had had a response to looking at prior TOFA versus JAK inhibitor naive, there wasn't much of a difference there. So I know it's hard to jump around so much, but trying to cover all these different things. So we talked in ulcerative colitis, particularly, we talked about vedolizumab versus some of the other agents, particularly TNFs and TOFA. We talked about some of the alternative agents that are newer, and then we're moving over to ustekinumab, Skyrizi, sorry, for Stelara. And one of the things to keep in mind here is that it has reasonable efficacy. Looking here at 3 different doses. And over a longer period of time, there's good sustained benefit after the infusions. There's a low risk of antibody development, so it's 3% at a year. Low infection risk, so that this blocks IL-12 and IL-23. And we'll talk further about the IL-23 inhibitors. And adverse events in terms of significant infections is really, when you look across the board compared to placebo, is really remarkably safe. In a head-to-head for Crohn's of ustekinumab versus adalimumab, they were really equivalent. Maybe a signal in terms of safety for ustekinumab, but efficacy was very similar, and perhaps more of a durable benefit here as well. So looking at these two, as a first-line agent, people are increasingly staying a little while ago saying that ustekinumab or Stelara would be reasonable. And then came along the ustekinumab versus risankizumab, so the Stelara versus Skyrizi in terms of those names. And you can see here that it was recently, we haven't seen the full data yet, but just some information. And risankizumab really doubled the remission rates and endoscopic remission in terms of overall clinical remission very impressively. Now, this was at every 8 weeks for both. If you shorten the interval for the ustekinumab, maybe that would boost up the rates here. But very important to consider this when you're looking at what would be your first-line agent. Now, risankizumab is not yet approved for ulcerative colitis. We expect that will be soon, but you do have mirikizumab. which is an important agent. But this is a head-to-head trial of these two. Keep in mind the difference here is ustekinumab is against IL-12 and IL-23, and risankizumab is just against IL-23. So is two better than one? It's probably not in this case. It's also worth keeping in mind that in terms of safety, it's about 8% of people have a defect in IL-23 and don't make it, so that when you worry about knocking it out, well, those people who don't have IL-23 really do very well. They don't run into troubles with infections otherwise. And similar with this antibody, this works quite well. So the last head-to-head trial we have is Sonic, an old study done in 2010, not that old, where it was really azathioprine alone versus infliximab versus both, and there was this significant improvement. And so this is important to keep in mind. I think a lot of people are hesitant to put people on both infliximab and azathioprine for a newly diagnosed patient, but it can be quite effective. And there's some newer data we'll look at quickly that supports this even more. So this is this study done out of Cambridge, where they took patients who were recently diagnosed and they started them right up on sort of top down versus more gradual acceleration of therapy and step up little by little. They had this was just presented to DDW as well. It was a multi-center randomized open label biomarker study. The biomarker was not effective in identifying patients who are going to respond. But in terms of the overall groups, when you took top down versus step up, and I won't go through all this, it's a little bit complicated. We don't have too much time. But they would step up at different intervals if people weren't doing well, as opposed to just starting right off the bat with infliximab and an immune modulator, that at the end of it, there was more of a sustained steroid and surgery-free remission with the top down rather than the step up. And here you can see that steroid and surgery-free remission. Now, does this apply to other agents that are started early? It's not clear, and it doesn't mean you need to start everybody right away on this combination therapy, but it's important to do something early on, that the longer you wait, you're more likely to lose some of the benefit of those agents. And here, this is a different type of way of looking at this. This is sort of across the board, looking at responses from randomized clinical trials. This is for induction of clinical remission. As it goes more to the left here, that favors the experiment. This favors the placebo, and these are all the various ones. It's harder to get a clear comparison across studies, and a lot of this overlaps. So whether you're looking at infliximab, risankizumab, or adalimumab as the initial studies here, there's a good deal of overlap and some variation in these studies. But this is the top line data for each of these studies. It's hard to really make a decision whether one is clearly better based on this. And fortunately, we have quite a number that are better. So how do we make some of these decisions? What group responds best to an anti-TNF? Certainly, perianal disease, we can get more of a sustained benefit. We don't have placebo-controlled trial data for all the other. We have more secondary derived data. A younger age and more extensive or more proximal disease may respond better to an anti-TNF. Probably earlier in the disease, again, there's some data somewhat conflicting that if you wait to start an anti-TNF or whatever that first line is going to be, the response isn't as good. There's also a faster loss of response with more side effects in the elderly, and we'll talk about that in a moment. So those that are smoking have reduced response. Age, pediatrics better than adults. If someone has a vitamin D level that's low, there's a reduced response, so it's important to check that. Disease duration, as I mentioned. No real difference, maybe a little better in some for ileal disease, but overall not a big difference. Durability is less in elderly, and side effects are greater. The common immune modulator really is primarily for infliximab and that might just be by boosting up the um, uh, levels of infliximab. A little bit on timing. We don't want to wait until it's too complicated. We want to wait until earlier in the disease. Once it gets sort of further out here, you've got more stricturing and penetrating disease, and you may have lost some of the window of when you can be of benefit. Now, when they did this in the pediatric risk study, they took newly diagnosed people, and they looked particularly at those who were at risk for disease complications, older age diagnosis, African American, and ASCA positive. And then they looked at early anti-TNF therapy. That was associated particularly with a reduction in complications with penetrating disease. So fistulas, abscesses were less. When they looked at stricturing disease, clinically they improved transiently, but ultimately that stricturing didn't improve. So when you look here, at the inflammatory disease as the top line versus the those with, sorry, this is B3 at the top. This is B2 and this is B2 or B3. You can see that the complication-free survival with an anti-TNF was less impacted for stricturing disease than it was for penetrating disease. And if someone got an early TNF for B3 here for penetrating disease, there was improvement. But if they didn't get early treatment, then much of that benefit was lost. So particularly for fistulizing disease, treating early is effective. Stricturing disease, it can improve things, but not as well. When we look at which anti-TNF to use, they're really very similar in terms of responses. Perhaps certolizumab isn't quite as good, but roughly about 20% over placebo for response and remission. But which to start? Well, it looks like perhaps in Crohn's that infliximab does have a better edge. When we compare it to vedolizumab, it's not as good in Crohn's as it is in ulcerative colitis. And when we looked at a large group of people, this is Ed Loftus, of people who were started on infliximab a little while ago, versus adalimumab versus certolizumab, this is persistence at 6 months. It's kind of disappointing. A lot of people break through and then need something else. Now, it might be that these were optimized, and there are ways of trying to improve that, whether it's dose, whether it's checking levels, checking antibodies, or doing concomitant immune suppressants. But it's still somewhat sobering to look at this when we think in terms of what's the persistence. And when we look at certolizumab, is really a little bit dismaying. So safety, again, we want to, this is just looking at some of these, we want to avoid steroids because the greatest risk in infection and mortality is really when you start up with steroids and then keep someone on steroids for a long period of time. When we look at anti-TNFs, the biggest risk is infection, but there's a whole host of other things that we need to keep in mind. There are a variety of autoimmune kinds of processes, whether it's psoriasis-like reaction, MS-like reaction. Fortunately, all those are rare, but I think it's important to keep those in mind. And some of the newer agents have much less of a risk of things like psoriasis, which can be 2 to 4% in those who go on to an anti-TNF. And then when we look in the elderly, there's much greater. So when we look at those greater than 65 versus those less than 65, we look at infection for hospitalization, you can see there's a dramatic change in terms of much greater in somebody who's over 65, and even in terms of death and malignancy. So I think it's important to keep this in mind and use this as a guide in terms of perhaps not using an anti-TNF as a first-line agent in someone who's over 65 and preferring to go with someone with an agent such as whether it's vedolizumab or one of the sort of risankizumab type approaches. Keep in mind here also that there's physiologic age and there's calendar age, and that may weigh in here as well. There's immunogenicity with the biologics, with a small molecule, you don't really run into that. And with particularly those that have a greater risk, such as infliximab, using a concomitant immune modulator can be very helpful, and using it on demand and possibly monitoring levels a little bit more closely may reduce that risk of loss as well. I'm going to jump over this, a little bit hard to see, but this is sort of looking at serious adverse events at a whole bunch of agents across the board. And really, when we compared all the different available agents, it really would say that there's no significant difference between this. There's some subtlety, though, changes here, but it really suggests that they're all roughly equivalent. I think some of the data doesn't support this in terms of some of the agents, but overall, safety is remarkably good, and there's some data to suggest that really it's equivalent in terms of safety. So I just wanted to mention again these TNF provoked autoimmune diseases. Each one individually is pretty uncommon, the most one being psoriasis, but keep in mind autoimmune hepatitis. All these other ones that are so-called autoimmune are very rare, perhaps 2 per 1,000 for something like the drug-induced lupus. And most of these, almost all of them go away, but not all of them go away once this is stopped. So what cases with more certainty can we use certolizumab? Pregnancy, TNF-induced psoriasis, switching over to either ustekinumab or risankizumab. Recurrent skin cancer is probably better to keep with vedolizumab. It's not going to be affecting that, and possibly for recurrent infection, going with vedolizumab as well. Should we change how we position biologics and their use in ulcerative colitis and Crohn's? Certainly. Keep in mind that earlier is better, probably. Selection of patients is paramount. Fistulizing disease for early on for an anti-TNF. Smokers, trying to get them to quit smoking, but they're going to have a blunted response across the way. Younger patients are going to have a better response. Generally, in strict string disease may need an alternative line because anti-TNFs really aren't going to change the natural history there. Is risankizumab better? We don't have head-to-head comparison. We have for others, but I think certainly for the elderly and those at higher risk of infection, risankizumab would be preferred. Vedolizumab, probably better as a first-line agent, particularly for those who are older, who have multiple comorbidities, those who have congestive heart failure. That's an absolute contraindication for an anti-TNF. For long-standing disease, and though for young, healthy patients, they're not clearly at a big risk and not clearly a benefit of vedolizumab over something like infliximab, and though a separate question for those with a prior malignancy. Ozanimod for ulcerative colitis, concerned about those who have prior MI or CVA in the previous 6 months, and you need to check an EKG before and then titrate up. But once you've gotten through there, there's reasonable safety and efficacy. I think a lot of us have tried to move this more forward, and where this will settle out, we really haven't figured that out yet. Etrasimod has an important contribution as well. To mention again, risankizumab as a first line, not yet approved for ulcerative colitis, though it should be soon. It's low immunogenicity, good durability of response, low infection risk, low risk of serious adverse events. But the big issue is, are we going to be able to choose, or will the insurance companies tell us? There's a strict FDA definition and indication with some prior to anti-TNFs and some after, but I think some of that's breaking down, and certainly some of the laws in the United States are trying to say we don't have to, the insurance companies can't say you need to fail first or step through, and that we can try to go ahead to some of the preferred first-line agents that we would like. Insurance can sometimes be limiting. This is at least a while ago. I think they're being less restrictive now in terms of using ustekinumab. They are a little bit more lenient, at least in Massachusetts, in terms of shortening the interval of ustekinumab. But that's a separate kind of talk that other people will be addressing. So we're now at a point where we have a whole host of agents, particularly the P19 IL-23 inhibitors, risankizumab, mirikizumab for ulcerative colitis so far, Amvo, and then others that are coming down the line. So we'll have a host there. We have a number here of the JAK inhibitors, and more will be coming down the line. And then we have the anti-TNFs here, and we have the cell adhesion molecule antagonists and the S1P medication. So you've got already a confusing picture, and then more on the way. So it's important to keep in mind the safety issues, particularly for vedolizumab, are impressive, but a little less effective for Crohn's. I think that we have some of these P19, like risankizumab, are emerging more as first-line agents for Crohn's and possibly ulcerative colitis. And then some of these here, the JAK inhibitors, moving more towards upadacitinib as something that can be very effective in ulcerative colitis, sometimes effective in as little as a few days. It's almost head spinning and can be extremely effective and helpful both inpatient and outpatient, but important safety things that need to be monitored for. So I've rushed through things very quickly, and I hope it wasn't too fast. I hope that will give you a brief, if not dizzying, overview and thinking through some of the issues. I think it's hard to keep all of these agents in mind at once, but I think it can be done, and I think that this is a good opportunity to really serve our patients well. Thank you very much.